EMDR is considered an evidence-based first-line treatment for trauma. But what is it, and how does it actually work? Welcome to the Art of Therapy, Season 3, Episode 24.
Oh, it's just exciting to continue with you on this journey of the art of therapy.
I share that,
Yes. And just to look at the last episode, we really had a look at what is, when around hypnotherapy, when is it indicated and when is it not indicated? And I think what just became so apparent is that it's just the same as any other therapeutic procedure that will be utilized in therapy.
Yes.
And it is for therapists just to be considerate about what is the nature and quality of the relationship, what is the therapeutic objective, and then, of course, just for the client to give consent to it. And when these things are in place, then hypnotherapy is indicated.
Yeah, you've said it so beautifully, so clearly.
Yes. And then we also just said that we're exploring therapeutic procedures and just different therapeutic procedures. So having a look at another one, and that's EMDR.
Yes.
And that we'll start to explore that today.
Yes. Okay, so when we look at EMDR, eye movement, desensitization, and reprocessing, we see a therapeutic application that is effectively indicated for trauma, to some degree, anxiety and depression, especially related to trauma. And it is really considered something of a first-line treatment for trauma. And this is by the American Psychological Association, the World Health Organization. So really something that is considered evidence-based and a first-line treatment. So it is, I think, important to review it and to understand it, given that we are looking at some of the developments and working and moving from a more integrative approach. But it's also important to note that there is some controversy around EMDR, which we can look at some point.
Okay, that sounds good. So I think maybe if we can just maybe have a look at where did it originate. And
Yes.
now it's an interesting story about how Francine discovered this as well.
Yes, it is. So it was developed by Francine Shapiro, and she had passed on in 2019 at 71. But she had put a great deal of work into the development. She discovered, as it were, and developed it. And if one just looks at how it emerged and the way she tells it, was really going back to 1987, and that she was out walking in the park and was at a small lake, and there were ducks, and there were, as she says, mothers and babies, and she was walking, through this park. It was spring, and she was both thinking about something that was disturbing and looking around, and then how she tells it, that she realized at some point that somehow that disturbing memory wasn't quite as distressing, and that she identified that it had to do with the way her eyes were moving from side to side as she was looking around. And that became the basis for the therapeutic approach that she developed, which was the eye movement. And effectively the desensitization. It was initially called EMD, eye movement desensitization, based on her approach of just by moving the eyes, the bilateral stimulation, that it's associated with a reduction in distress and any kind of disturbing or traumatic memory. She later began to identify that there seemed to be other aspects developing the way people manage their emotions, some of their insights, some of the beliefs, new beliefs that were developing. And so now she included that there was more than just a desensitization, there was also a reprocessing. And she now called it eye movement desensitization and reprocessing. So EMDR, and that's how it's known today.
Okay. And that's how it was her journey of discovering this and making sense of her experience.
Yes.
That she was able to look into and try to make sense of how it changed for her with regards to a traumatic memory that she actually sat with.
Yes, very much. Yeah.
With EMDR, so with what is the process of EMDR?
Okay, so the overall view that she has, let's just look at how she conceptualized it. She conceptualized it in terms of what she called the adaptive information processing theory, AIP. And really what that has to do with is, she said, we've got a sort of a natural innate ability to process experience adaptively. But when there's a trauma or some traumatic impact, she hypothesized that overwhelmed that processing ability, and at a brain or a neuro or cognitive level, that this would mean that the trauma had not been fully processed, and unprocessed would continue to trigger disturbance and distress for the individual. Again, that's why the approach, what she added, was the reprocessing part, helping to reprocess these said traumatic memories. So that's the theory or main working hypothesis. And so if we just look at EMDR itself, there's basically, it's an 8-step protocol that is employed. And usually you're going to be looking at, for EMDR, about 6 to 12 sessions. That's on average, with your sessions, 60 to 90 minutes. And the basic protocol is just as we would take it one step at a time. The first is history taking, really trying to understand the person's history, any traumatic experiences, and some of their present functioning. So really that would be fairly standard. Then the second phase is really a preparation, which of course involves establishing a really meaningful therapeutic relationship, identifying the target trauma, what the client wants to be working on, and the kind of what's actually happened there, because it's really important to be very, very specific in dealing with trauma. And so really getting that. And then the next step is something of, as one would look at it, really starting to do an assessment. But if we even just go back to the preparation, not only is that identifying the actual trauma and that one's going to really focus on, but it's explaining more about EMDR. And something that one will introduce there is the kind of stimulation, bilateral, the movement of the eyes, or it's going to be possible bilateral tapping. And sometimes one can use sounds, or a system where you've got vibrations in either hand, again bilateral, left and right. So just explaining the system. Also, given that it's going to be trauma work, helping them to develop relaxation, breathing, meditation, just so that should there be distress, that they have a safe place that they can they can experience and be calmed. So that's all part of the preparation.
A lot of skill focused in managing stress and trauma.
Yes, very much. Yeah. And one can see they're utilizing therapy, therapeutic skills and existing knowledge around therapy and how to do that meaningfully. Then the next step in the protocol is really the assessment itself. And in the assessment, one's really going to look at, again, the target, trauma. I'll come back to that. But the other part is, how does someone want to feel? What do they want to believe? Because very often with a trauma, there's been some disturbing beliefs that are associated. So another part is understanding, how does someone want to experience this? Or not so much the trauma, but now their belief about it. And that's the second, and getting them to identify exactly what they would like that belief to be.
Okay.
Having done this, let's just look at the trauma part itself. There's going to be a baseline measurements, 2 questions, which is really, the first one is a scale, which has to do with subjective units of disturbance, SUDs. And on a scale of 0 to 10, just how disturbing is that trauma?
Okay.
And the client's going to give a rating out of 10. 10 being maximum disturbance, distress, horror, whatever that is. And then the second rating is going to be related to the belief, the validity of cognition. So to what extent does someone believe or have a sense of authenticity and really take hold that belief that they would like to have? A scale of 1 to 7, 7 being absolute conviction, certainty that really they believe it. And then the client will then rate that belief. Expectantly, because it's something they've just developed, it's going to be lower. Yeah. So now, having done the assessment, the step 4 is actually going to be the desensitization itself. And in the desensitization, the therapist will ask the client to bring up that trauma and hold that trauma. So bring it up, bring to mind, and the most visceral, the most disturbing, distressing part of it. And to hold it there, while the therapist then, if we're going to take the more classic approach, would be just moving the fingers very quickly, left and right. And it's about 30 to 60 centimeters away from the client's face, and doing so fairly rapidly for about 30 to 60 seconds while the client holds this memory. And then just saying to them to just take it after that, bring the hand away, just saying to them to take a breath. And that helps calm. And then asking them what comes up, what sort of emotion, thought, what comes up. And then asking the client to then rate that in terms of the SUD.
Okay.
And the client gives a rating. And then that procedure is effectively repeated. So bring it up again, going across for about 30 to 60 seconds. Take a deep breath. Okay, what came up? And then getting them to rate. And the client keeps rating this effectively until the SUD or their experience of that traumatic memory is at a 0. So it's come all the way down. Yeah.
It really is a desensitization process.
Yes, very much desensitization. Yeah. Then the next step is the installation process, where one is now going to look at what is the positive belief. And remember, that was rated earlier in terms of the validity of cognition. And so now the therapist will ask the client to bring up that so-called traumatic memory and hold the new belief, positive belief, while doing the bilateral stimulation again. And after about 30 to 60 seconds, it's getting them to take a deep breath again. And what comes up, and very often now talking about the thoughts or the belief, and then again the rating. But this time the ratings in terms of how believable, how much do you really experience that belief now? And the client will rate. And very often that's what's going to be happening then each time, and it will happen, that becomes more and more believable. And this will be repeated until the client can hold that previously traumatic memory with the positive belief, but now rate it as a 7. So that it's fully believable.
That's where the reprocessing needs.
That's where the reprocessing, indeed.
Okay.
And then the next step would be the body scan, where what the therapist will ask to do is hold the traumatic memory in mind and the positive belief, and then perform something of a scan, a mental scan of their body, and see if there's any lingering sensations, feelings in the body, anything that disturbs, anything unusual. And then and if there is, then again doing the reprocessing and checking until that body scan shows that there's nothing lingering. Then I said there was 8 steps. So the 7th step is then going to be what we considered closure. But almost every session ends with closure, just helping the client calm if they need to be calm, just settling, bring any anxiety or stress down, just ensuring they're in a calm, centered, more relaxed state. And then your last phase in the protocol is your reevaluation. And that's usually done every session. And every session begins with a reevaluation based on the experience of the desensitization and the reprocessing that occurred. And that basically is EMDR, and one would continue the therapeutic application really until such time as the trauma rating is down to 0 and the positive belief is now rated on 7.
Psychotherapy is not only a profession, it's a state of being. And for that, it requires continuous learning, training, and refining your skills. If you would like to become better in your role as a psychotherapist, come and join Dr. Warwick Phipps for in-person training at Treatment Works Centre, where you will experience training like never before from a thought leader and expert in psychotherapy. If you would like some more information on our training or to book a training session, please visit the link in the description. And also, if you find these podcast episodes meaningful, please subscribe to the Art of Therapy. It sounds like a very, very practical, structured approach to assist with trauma and to desensitize and to reprocess.
Yes, very much. And I think that's why there's such an appeal for it, because it's very structured, very pragmatic. And those in healthcare and mental health deeply want to assist and help others and relieve them of their distress.
So that actually helps, because then because it's so practical and you can check it out, then it's really helpful to track it as well.
Yes, very much. Yes.
Just being able to understand EMDR and just how it was developed, and so understanding the desensitization and reprocessing. How because I think with just different procedures, it can be looked at from different lenses. Where can that fit in, or what lens can it be looked at?
Yeah, so this is really where something of the controversy comes up around this procedure, because as it was developing, there was more research, and one of the studies conducted really compared EMDR. This was going to 2016. Compared EMDR with bilateral stimulation and compared it with EMDR but no bilateral stimulation, just a fixed point in hand. And what was found was there was no significant difference, which was really confusing and surprising, because the approach is based on bilateral stimulation. Also, there'd been other studies that had demonstrated that there may be there could be effects even without the visual bilateral stimulation. Again, touch or sound alternating between the left and right ear. Or I noted earlier the vibrations moving between left and right from vibrating objects. So it now became really unclear what is having this so-called therapeutic effect.
There is a therapeutic effect, but
yes,
why?
But why? Yes, exactly. And so there have been so many theories put forward. Probably the leading one today, it has the greatest support, is the working memory taxation theory, which really indicates that with working memory there's a limit, and the task of both bringing up the traumatic memory while noting and staying focused on the moving fingers to some degree overloads working memory and limits the experience of that trauma, how visceral it is, and there's a effective reprocessing. That's one. There's been another, the dual attention hypothesis, that being aware of something in the past but staying aware in the present affects some kind of reprocessing. There's been a hypothesis about that it's bilateral. Somehow the movement stimulates the different spheres of the brain, and there's this bilateral stimulation that somehow affects some kind of relief or reprocessing. How or exactly why is still unclear. So these are all hypotheses, but it still remains really unclear as to, is this a valid hypothesis? Why? Also, it's a lot of the research that was done in EMDR. There are questions about researcher bias that comes up a lot in psychological research. Also, there are indications that the more training or the more experienced the practitioner, the higher the efficacy, but that begins to then suggest that there's more to the EMDR than just an application, that it has to do with the therapist's skills. So there's quite a lot of controversy surrounding this.
It is. It seems like there's people report that it really works and it's effective, but we still I'm not quite sure how come and the why.
Yes.
There's a lot of hypotheses about it.
Yes. Yeah.
But it does create a very structured and predictable way of assisting someone.
It does. And I do think you asked an important question earlier, like what are the lenses that one can look upon this? And if one just considers something, the utilization of the eye movements and what's occurring, one can't ignore when you really understand hypnosis. Just a consideration of a hypnosis lens. Maybe just to back up as well, Francine was actually very interested in neuro-linguistic programming. She actually set up the Human Development Institute in San Diego in her earlier years, and really that was orientated around NLP principles. And as we know, and as we've discussed, NLP was really based on the observation of Milton Erickson and his hypnotic skills. Again, there's some controversy about NLP itself. Certainly, Milton Erickson was profound in his ability to work therapeutically, his utilization of hypnosis. But NLP was really an attempt to model some of the communication processes of especially Milton Erickson. But the basis there is hypnosis. And Francine was really interested and was doing a lot of work around NLP. And of course, one of the big developments in NLP, when I say development, there's a lot to be looked at, but it had noted eye movements, and that eye movements and the placement of the eyes up to the left or right, what kind of eye is associated with various ways of thinking, visualization, hearing, kinetic, or touch. So she was already familiar with that. So it is interesting. Just first one looks at the background there, and an emphasis indirectly with hypnosis. But even if it weren't for that, one can just look upon the application. And we know now, as we've been discussing hypnosis, that the moment that you ask someone to, if we just move like this, yes, while at the same time bringing up something traumatic, very often you're immediately going to have a bypass of the critical faculty. And although when you're doing the bilateral stimulation, for instance, you're not talking, certainly we know the effect of going into a state, and it can just be a waking hypnosis state, eyes open. But there's also an expectancy, there's suggestion every time you repeat the measure, both for SUDs. There's both the suggestion and expectancy that it's going to go down, and then the validity of cognition and really believing and the authenticity or confidence in that positive belief moving up. And then with the smart therapeutic work that goes on, what did you notice or what came up for you? And then beginning to do some of that, challenging any, cognitions that aren't helpful, some of the cognitive restructuring, just very much part of meaningful therapeutic work. We also know that once one emerges, it's interesting that when you ask someone to take a deep breath, sometimes they'll close their eyes, they're emerging again. And yes, there's still possible bypass as you're talking to them. And what is interesting is really you can just have someone in hypnosis just close their eyes and then just imagine that that's happening, that movement is continuing. And someone needn't even just be moving their eyes, they can just imagine it along with the any therapeutic suggestions. So what's really interesting, it's not to say it is hypnosis, but if you look upon it, once you understand hypnosis, there's certainly a considerable overlap. Let's say that.
Yes. And it's one way to try and make sense of it, and that there is overlap of hypnosis and EMDR, and that actually helps us to understand it better.
Yes. Yeah.
And I think just when you mentioned that selective thinking, and it would usually be something that someone would really want wholeheartedly.
Yes.
And that also makes a difference then.
Yeah, very much, because they want to be able to experience relief of trauma, and then that positive belief that they want to have, they really do want that. And if one can facilitate here, just as is done in EMDR, possible bypass, if we look at it, yes, that selective thinking can be very significant and experienced wholeheartedly.
It's a very interesting process to look at, and just to try and make sense of it as well, and that this is one possibility of trying to make sense of it.
Yes.
But it's a very structured way to assist clients, and to a therapeutic procedure then to assist clients as well.
Yes.
If I just reflect on just where we came from at the beginning of this season, we've covered a lot.
We have.
And I think we almost got the sense we've covered so much, but also just a tip of each modality and procedure as well.
Yes.
And we're also part of looking at an integrative approach. So I'm just wondering, if we, having looked at all of these different modalities, so how do they fit together in a systematic, integrative way?
Yes. It's usually you saying, hold, at this point I'll say, hold, let's review that in the upcoming, because we have covered a great deal, and we can explore some of the principles of what may be part of an integrative, and how to start bringing them together, these different modalities.
Okay, I'm looking forward to that.
Yes, I share that.
Okay. Thank you for joining us on The Art of Therapy. If you found this episode meaningful, or if it expanded your knowledge, we would love to hear from you in the comments section. We are looking forward to continuing this journey with you. Until our next episode.